Warning, this episode contains brain food that will lead to improved emotional and social intelligence. Thanks for tuning in to Harvesting Happiness today for a healthy serving of consciously prepared brain food. This is Lisa Cypers Kamen, your host. For more than 13 years, I've been handcrafting these sound ideas for better well-being. Each week, I love spotlighting diverse thinkers and doers who are contemporary trendsetters and change agents, devoting their lives to creating a better world in which to live. I invite you to listen up and change the way you think about human happiness. Our award-winning content is fresh, optimistic, and purpose-driven media that promotes well-being from the inside out. Alrighty then, let's dive in. This episode offers psychosocial education designed to inspire and motivate our listeners. The information provided does not constitute a therapeutic relationship nor a substitute for professional mental health care. If you are experiencing a mental health crisis, call 911, go to your nearest emergency room, or for listeners in the United States, text 988 for the National Suicide and Crisis Lifeline. Good morning, good afternoon, and good evening, wherever you are. Thanks for joining me on today's show, where you will learn about constant cravings, contemporary solutions to addiction management. My guest today is Dr. Joshua Lee, MD. Joshua specializes in medication-assisted treatment of alcohol and opioid use disorders. He conducts clinical trials and treats patients struggling with addiction as a primary care physician. As a professor at NYU Grossman School of Medicine, he leads the Addiction Medicine Fellowship and conducts research focused on justice and community outcomes. Josh is ready to explore the intersection of addiction treatment with innovative solutions and personal as well as professional growth. Josh, thanks for joining me on the show today.
Lisa, great to meet you. Great to be here.
First of all, let's talk about humans' brains. We are pleasure-seeking missiles. We love to feel good. Let's just start there.
Yeah.
But sometimes things kind of go awry.
Yeah. Yeah, agree. Yeah, it's so interesting. We love new things. And then, of course, how did we get all involved in addiction, which is, I'm sure we'll talk a lot about that today. And it probably was just natural accidents that we figured out over the ages, this stuff that was disproportionately pleasurable that didn't otherwise, you didn't find it in the forest or the field or the stream. But if you made it, or if you did happen to find it, I guess you could find naturally occurring alcohol, fermented fruit, for instance. But, to get to a joint or a can of beer took a lot more work. And it's just how our brains were programmed. We are susceptible to liking that stuff. And you can talk about all sorts of overeating and food and stuff that makes us just go a little berserk in terms of how much we want to use it, repeat it, learn about it, in terms of relative to any other stuff we could be doing with our time.
Having said that, what we can agree that we love pleasure. But when pleasure goes awry, we get too much of it and our lives start to fall apart and we, are teetering on the edge of disaster. That's where we step into the addiction territory, where we're not able to self-regulate. We're not able to dial it back. And this is where your research comes in. And I'm super excited to share all of this.
Cool. Yeah. My research is very much applied treatment. So once they have a new drug and once it's FDA approved, how do we use it in primary care? How do we use it in criminal justice settings? One study we're doing now, which is a large multi-site study, is extended release buprenorphine versus extended release naltrexone, which are two available on the market long-acting products for opiate use disorder in criminal justice involved adults, and looking at kind of how they compare side by side. So very kind of basic bread and butter, helping the treatment community kind of stack one option against the other with large randomized trials. That's been kind of my career's work.
So in your research, what is the difference between somebody who is taking a medicine-assisted approach versus total abstinence, which for many people is a white-knuckle experience?
Yeah, we encourage folks to use the best treatments available, and then to look for realistic, achievable, and meaningful goals. And that could or could not be abstinence. As we know from smoking, say, it's kind of a new world of smoking with, for instance, e-cigarettes. So what if I can get a patient to quit smoking cigarettes, but now they're vaping? That to me as a primary care doctor sounds great because you're not using inhaled high energy cigarette smoke, which has all the kind of bad stuff in it. Being on nicotine isn't as much of a problem if you can do it safely. So the nicotine dependence and the kind of addiction to nicotine products of whatever kind, that's like problem number 2. And maybe we still have to solve that later. But the first order business is just using nicotine more safely if you otherwise are not ready to quit altogether. But that's like a new way to like talk about smoking cessation with a lot of our patients that is not abstinence based. We're not saying pick a quit date, never smoke again, bare knuckle it through those first 2 weeks. When I was growing up, I remember seeing TV shows where like shock therapy and hypnosis were important for smoking cessation. I don't know if they ever were, but like in my mind, they were. And we probably don't have to be that dramatic. We can be much more practical and we can do stuff that fits people's kind of lifestyle. It does not have to be this like dramatic, this is the month I quit smoking. It can be, and for some people that's going to work better. But I'm going to kind of talk to my patients up front about like what do you want to do, and here's some kind of options to go about this. And that may or may not be abstinence. So it does break from traditional models of addiction treatment where you got to get sober. That means nothing at all. It may even mean no medications, no behavioral health medications, no, opiate agonists, if you're talking about methadone or buprenorphine, maybe no naltrexone or disulfiram or acamprosate for alcohol, which as a primary care doctor, that's my background and perspective, has always been absurd. Like, why would you not want the medications that are designed to help with this condition? Why are these medications somehow more stigmatized and different than medications for other disorders like diabetes or hypertension? Like, do you feel bad that you're on diabetes medications when you have diabetes? Most people don't, although of course nobody wants to be on a medication for life. So I've never really kind of practiced or recommended strict kind of abstinence treatment models.
Well, the harm reduction model is one that is very much a la mode, right? People are recognizing that doing less of a bad thing is better than doing nothing.
That's right.
And some people do eventually come to the place where they realize, A, they can learn to regulate and socially drink or whatnot, or they decide, you know what, I really do need to go the next step. But having the ability to do it in tiny steps, is very, very helpful. And I think this is where these medications do come in and assist us well.
Yeah, totally. And the mantra of kind of modern medicine is patient-centered care, meaning it's different for different patients. And no one can escape the fact that like lung cancer might kill you. Like that's not patient-centered. We need to do something about everybody's lung cancer. But the kinds of treatments people are going to be interested in, motivated towards, and then ultimately be able to realistically accomplish, there's a wide spectrum. And so I want to work with each patient's on kind of individual goals that are within kind of a zone of it's all going to help you. And we were just talking before this podcast about weight loss, and like you just can't expect everyone to lose 50 pounds, right? Like it's going to be a struggle. It's going to be a journey. It's going to be different for each person. There's going to be a combination now probably of medications plus the standard diet, exercise, kind of change your lifestyle. And what are we going to, we're going to tell everyone they're a failure when they don't make a goal by a certain point. Like we know in that kind of basic behavior change model, you don't yell at people, you don't lecture, and you don't have a one size fits all approach. So that's always appealed to me in addiction as a primary care doctor. Like, let's just work on practical, effective solutions, and it'll be different depending on the person.
And recovery is not linear. I think that's also really important to talk about, because in my experience, you will have a client or a patient who is going through treatment, whether it's inpatient, outpatient, which both take a lot of dedication and focus. And most people do not have the luxury of peeling away from their lives for an extended period of time to, air quote, work on themselves. Yes, it would be optimal. But I think what we're talking about a nonlinear or harm reduction approach to health and recovery, is that we're willing to walk with that patient or client on the journey, and there will be setbacks and there will be progress. And it's sort of the total experience that we need to work with.
Yeah, I totally agree.
We are going to need to take a break. And when we come back, we will continue the conversation with my guest today, Dr. Joshua Lee. We're talking about constant cravings, contemporary solutions to addiction management. To learn more, please visit orhealth.com. And we're going to tell you more about Or Health when we come back. And you can find Dr. Joshua Lee at Dr. Joshua D. Lee on X, also known as Twitter. Here comes the pause. We'll be right back. Hang on. Before we take that break, I want to remind everyone about the preciousness of time. Let's face it, we're all overprogrammed without enough hours in our days to get it all done. And we all want good hair days, but we're too busy to tussle with our tresses to get that frizz-free salon quality look we love. That's why I've added Ouai's new anti-frizz cream with the signature Bondi North scent to my time-saving hair care routine. This lightweight cream provides immediate frizz control that lasts for up to 72 hours, plus provides heat protection to 450 degrees while helping to reduce and repair split ends. My hair feels silky, soft, and smooth, and smells like I'm on vacation. The beauty of Ouai's new anti-frizz cream is that my hair goes from wild to tame in a jiff. Don't you just love instant gratification? According to a recent user perception study, 90% of participants agreed that their hair looks less frizzy. Ouai offers a complete hair care solution that promotes fuller looking, healthier feeling, and happier hair for everyone. Fine, medium, or thick hair, Ouai has got you covered. Treat yourself to great self-care and good hair days with Ouai's best-selling products like their leave-in conditioner, detox shampoo, travel destination-inspired fragrances, hair oil, and hair gloss. Now you can get on your way and really mean it. Frizz-free up your schedule with Ouai. Go to theouai.com and enter promo code HH for 15% off any product. That's theouai.com, promo code HH. Now let's take that pause. Research tells us that happiness is good for our health. Happy people live longer, are more productive, and make better partners, parents, and professionals. Want more sound ideas for better well-being? Check out our new bonus edition content, More Mental Fitness by Harvesting Happiness, available exclusively on Medium and Substack. One thing I know for certain, happiness waits for no one, and at times we all need a little support. To learn more about lifestyle management and mental fitness consulting services, please visit harvestinghappiness.com. And we're back, continuing the conversation with Dr. Joshua Lee, MD. We're talking about constant cravings, contemporary solutions to addiction management. Let's get back to it. So, Josh, let's talk a little bit more about contemporary solutions, because you're part of a pretty neat company. In addition to the work that you do at NYU Grossman School of Medicine, you're also involved with another venture, which I think is pretty cool. So please share with our listeners.
Yeah, that's Or Health, orhealth.com. And Or is a company that has an app website doing a telemedicine version of alcohol treatment that is what we call asynchronous, meaning you don't dial up and do a video chat with a doctor or therapist for 45 minutes, and it doesn't bill your insurance. What we're doing is more of a retail direct-to-consumer product where you do the website, we verify your identity, you fill out some forms, we basically come to a conclusion that you have an alcohol use disorder and that you're appropriate and eligible for naltrexone or oral naltrexone, which is one of our standard generic decades-old therapies for alcohol use disorders. And that is what Or is trying to get you by mail. So it's a very simple, private, convenient, and kind of by mail version of alcohol treatment. And it's based on getting you one medication, naltrexone. So we can talk more about why and how, but that's the basic model. It's trying to strip down to the very bare essentials, what we think most people don't need their whole life or may need different stuff, but at least for the first line treatment episode, most people would be appropriate for giving this a shot.
What I love about this as a company and what you're offering is that some people may not be ready to really look at all aspects of their life and see where substances play a role, not just in the addiction component, but how it is affecting other areas, relationships, work, et cetera, et cetera. So what I love about this is the first line of defense, or the first place to try, is it helps one manage cravings, or ostensibly helps one manage cravings.
Yeah, we do think that is the case with naltrexone. We think that's one of the main kind of effects or benefits, that when you are not using, it helps suppress thoughts, urges, dreams, obsessions, kind of unconscious routines that remind you to keep using. And on naltrexone, if it's been a few days since you've had alcohol, people will generally report less thinking about it, not as interested. And then, of course, naltrexone works by suppressing kind of the immediate reward of alcohol. And so if you do have a drink, it's not as kind of fundamentally rewarding. It's not as fun. It's not as tasty. They're less likely to have a second, third, kind of have a heavy drinking episode. And that's the magic or the mechanism of action of naltrexone.
I have heard of side effects with naltrexone. Clients have reported nausea just from taking the medication, which for some people it doesn't bother them, for others it does. And then if you attempt to drink on the naltrexone, some people do get sick. They vomit.
Yeah, nausea or kind of tummy trouble is the most common early and probably general side effect. There is a version of the drug where you do a monthly injection, and there you probably avoid most of the nausea. So it is something about the taking an oral pill and having it absorbed through the GI tract. Generally, that's pretty tolerable or limited and gets better. People do get used to it, and they can start with kind of a microdose for the first 1 or 2 days. That's one kind of practical way to ramp up to the full daily dose. It is the most common side effect and the most common reason people can't tolerate naltrexone. That said, it doesn't occur at very high rates, and most people can tolerate it. As far as drinking on naltrexone, that's interesting. I've heard that too. I don't think we have great measurements or rates for how often that happens, but it is not a uncommon story that people feel that the idea of drinking once they're on the medication is kind of icky or turns their stomach and is not something they're immediately looking forward to. And that, of course, could be an effective, way for the treatment to work.
Let's talk about stress management and self-regulation, that this is an area that no drug can actually really prevent, right? That you have a triggering event in your life, and the reptilian brain wants to reach for the thing that has been the trusted friend for however many years to help soothe. So I think this is the one area that people need to be aware of, that there is no medication to solve that. Like, life is hard. There will be triggering things that happen. There will be trauma. And hopefully through the use of medication-assisted treatment like this, that we can then learn these other coping skills to support and sustain harm or refrain from harm.
And that's the whole project of long-term recovery is, with naltrexone for alcohol, for instance, most people don't take it for 5+ years, 10+ years. It's more episodic. We don't really have data. Should you take it for 5 years? Maybe. But most people eventually have success with it, get control of their drinking, and use it for a maintenance period, but not indefinitely. But you don't want to just 10 years later be back at square one with heavy drinking and an alcohol problem. So how do you kind of mature? How do you kind of relearn? How do you cope? And how do you deal with setbacks, triggers, as you say, et cetera? That's really where everyone's got to kind of do that work and figure it out, on their own terms. And that could be through peer, that could be through professional counseling, it could be through just good social support and kind of turning over a new leaf and learning routines. So that is kind of fascinating that people are going to get there in a lot of ways, but they all have to do the work.
And honoring that, as the people who treat people who come in for addiction, challenges, respecting the fact that there are many pathways to a sustainable recovery model for people. There's not just one way. And I think that that is where organizations like AA, who are amazing, right? I mean, the primary secret sauce in AA is community.
Yeah, I agree.
But one does not need to go to AA in order to get and remain sober.
I agree with that too.
Yeah. So, I mean, I think that's really important to talk about. Let's talk about the duration. We're nearly out of time, but I want to be aware of, like, somebody comes to, or for example, request the medication. What is the treatment period, typical treatment period that somebody would be taking the medication for?
It's not prescribed. It's indefinite. We would say at least give it a shot for a year, but we can take it a month at a time. Like we're generally going to start with a 3-month prescription. And that, let's say that's kind of a trial and error period. Like, can I tolerate the side effects? Is it helping? What do I feel overall? And if you've had success by the kind of 90-day mark, we're going to recommend you stay on it. And that's generally what most guidelines would say. After, say, a year, it really is kind of a lot fuzzier. We'll just take it however the patient wants. I've had patients in my practice in New York City be on naltrexone long-term for kind of alcohol maintenance. They're not actively drinking for the most part, but they want to stay on the medication. And that's fine. There's no known long-term side effects. You're not compromising your health in any way. You're just going to stay on a medication. A lot of people will arrive at a point where they want to pause it, but still have it around. Meaning if they're back in a holiday, high stress, busy, high, a lot of alcohol use time of year, they might go back on it. Or if they have that one night coming up where they think they could be triggered, they could take it that day, that kind of thing. And that's totally fine. And we'll work on any of that with patients. And then some people just want to pause and say, that was good, that was treatment, and I'm going to move on. And if I do have a problem, I know I can go back to it. And that's fine too. We hate to always kind of say goodbye to patients. Let's say we've worked together after 2 years. As a provider, you want to keep in touch with them long term. And as a primary care doctor, our time frame is forever. We're going to be your doctor forever. But it's also normal with alcohol treatment for people to have success with whatever the intervention was, including I started to go to AA. I was never on medication, but this has worked for me. Do people do AA for the rest of their life? Most people are going to have a kind of period where they start to dial it down a little bit, and that's probably fine.
Although as long as
they have support, of course.
Yeah.
I would say the average experience is not that, right? That people use it for a time more intensely, and then there's a kind of a graduation phase where they don't use it as much or are not as active.
I think that's accurate. I mean, in my family, there have been several people who have gone through addiction recovery. One was in AA for 50 years, and it was the thing that saved his life. I have another close family member that was an uncle. I have a stepdaughter who's been in recovery for 18 years, got sober, never looked back. And that's that, doesn't feel the need for that kind of community reinforcement. So it is really individual. And what I do love about how the treatment field has evolved is recognizing that there's just not one road.
Yeah, absolutely.
What else can we talk about here? Because we're almost out of time, and I want to make sure that we cover sort of the spectrum of what your research covers and what OR is offering.
Yeah, my work has really been just making these medications that work really well for smoking, opioid problems, and alcohol available more widely, get the word out. These are not drugs that are heavily marketed or have really a very kind of busy consumer lobby. So it's not like pharma is trying to sell you these drugs every day. And then the work falls on kind of folks that, prescribe them and care for these patients, and then patient advocacy organizations, et cetera. But we want people to know that addiction treatment does not have to be super complicated. There's a lot of medications that aren't all guaranteed to work, but you should give it a shot. And that for most of the common and kind of most deadly disorders we have, there's a pretty good practical solution you could get from a primary care doc. You could get from an app like Or Health.
Yes.
You could maybe even start in the emergency room. It's not the same everywhere you go for healthcare. We still have a lot of work to do getting people to just kind of, your average ED physician, know they can talk to patients about these problems and start treatment, that night in the emergency room. We're not quite there yet as a nation and as a kind of physician and other provider workforce, but we could be. We could just kind of make it that much more accessible, simple, cheaper, ultimately, and just less, dramatic, and then maybe get it less stigmatized so that people know about it and are interested in treatment earlier. Like, why not talk to your doctor in your 20s about your heavy drinking? Why wait till your 40s when it's really been this kind of decade-long disability? And then there's a kind of dramatic entry into treatment when we could have maybe been working on this long before that and maybe prevented some of the more severe consequences. So treatment doesn't have to be, too complicated or even time consuming. And you think of the ways that you could, start treatment for alcohol with a simple once a day medication. And that's kind of the message.
Well, I love that you're talking about destigmatizing addiction, because I think it is so prevalent in society, and society shames those who have this problem when in fact it's a very human problem. We're all touched by it, whether it's our own personal bodies or somebody that we love that has this.
Yeah.
And knowing that there can be at least a starting point where you could say to a patient, try this, and then let's see how it goes and see how you're managing your life. And then you can see what might need to happen next. That nobody has to marry this,
Yeah.
that they're trying it. They're seeing how it works. I think that's really important here.
Yeah, absolutely.
We're out of time. Once again, I want to send our listeners over to orhealth.com to learn more. You can find Dr. Joshua Lee on X, formerly Twitter, at Dr. Joshua D. Lee. Josh, thanks for hanging out. Thanks for sharing part of your day and giving us some information that I think is really important and potentially life-saving.
You got it, Lisa. Great to join today. Thank you.
Thanks. Thanks for joining us on Harvesting Happiness today. This is Lisa Cypers Kamen on behalf of my guest, Dr. Joshua Lee, MD, wishing you kind thoughts, kinder words, and the kindest of actions. Until next time, remember, happiness is an inside job. Happiness is your inside job. Please go out and rock your day, and remember to be kind to one another. Want to take a deeper dive into sound ideas for better well-being? Check out our new bonus edition content, More Mental Fitness by Harvesting Happiness, available exclusively on Medium and Substack. Keep harvesting your own happiness anytime, anywhere from the comfort of wherever you are. Subscribe, listen, and share hundreds of downloadable episodes from wherever you get your podcasts. Connect with and follow us on most social media channels. To learn more about lifestyle management and mental fitness consulting services, please visit harvestinghappiness.com. Harvesting Happiness and More Mental Fitness are produced by me, Lisa Cypers Kamen, Andrea Mengele, Robin Boyd, Andrea Daly, and the awesome team at Podfly Productions, including Eric Begay, Kimberly Beck, and Alec Guess, in collaboration with TogiNet Radio, KBUU, RadioMalibu.net, and is available on PRX, the Public Radio Exchange.